Welcome to the Hospital Medicine Unplugged podcast. Today we're focusing on one of the toughest, really high-stakes scenarios we handle in the hospital, deciding on lower extremity amputation. It's rarely elective, often urgent, sometimes chaotic, and it demands speed, precision, and just immense collaboration from everyone.
It really is. It's like walking a tightrope in acute care. Our goal today, I think, is to unpack the guidelines, the evidence, and maybe the ethical weight of these decisions. We want to help guide our peers through these situations by looking at clinical necessity, patient goals, and, the system-level stuff needed for success.
And that starting point, the principle that has to guide us when things are really critical, is life over limb. Before we even talk salvage, we need to be crystal clear about when immediate amputation isn't just an option, but absolutely necessary for survival. And often the hospitalist is right there at the beginning, seeing that threshold being crossed.
Exactly.
So let's get specific. What are those absolute life-threatening situations that just demand a primary amputation right now? When does life over limb become the only real choice?
Well, we're talking about situations where the limb itself is basically poisoning the patient or acting as a massive source of infection. The absolute indications. First, uncontrolled sepsis coming from that extremity, unresponsive to fluids and initial antibiotics. You might see profound shock or rapid organ failure driven by that limb.
So this isn't just a local wound infection, it's systemic.
Absolutely, systemic toxicity. Second, severe metabolic derangement. Think extensive tissue necrosis, wet gangrene, or massive rhabdomyolysis. The breakdown products, the potassium release, the AKI, it can all lead to cardiovascular collapse. If that tissue is clearly dead, the patient's profoundly acidotic, any delay for, say, a complex revascularization attempt dramatically increases mortality risk. The priority becomes source removal. Emergency primary amputation is the standard when life is acutely threatened.
That's a very high bar, obviously, for immediate action, but often it's not quite that traumatic moment. It's more of a slower process. So moving away from the immediate life threat, what about the relative indications? Situations where it's maybe less acute, but the limb is just, well, not salvageable or maybe even detrimental to the patient's overall quality of life.
Right. These relative indications often come up after initial salvage terms haven't worked or seem very unlikely to work. We're looking at things like persistent, disabling pain that you just can't control, even with opioids and nerve blocks, or a limb that's completely non-functional, maybe severely limiting mobility or needing constant consuming wound care.
And the patient's baseline function is key there, isn't it? Especially if someone is already nonambulatory or bedbound.
Oh, absolutely. For a patient who wasn't walking beforehand, pursuing complex multi-stage limb salvage can mean months in the hospital, higher infection risks, more suffering, often for no real functional gain at the end. In those cases, an earlier definitive amputation, while obviously a difficult discussion, can actually lead to faster healing, fewer complications, and, a better, albeit different, quality of life.
Okay, to really understand the scale here, let's look at the main reasons this happens. What are the most common underlying problems driving these major amputations in U.S. hospitals?
By far, the biggest driver is chronic limb-threatening ischemia, or CLTI. That's essentially the end stage of peripheral artery disease, often complicated by diabetes, leading to tissue loss or severe rest pain. The data suggests CLTI accounts for up to maybe 72% of major lower extremity amputations in the U.S.
72%, wow.
Yeah. It happens when the PAD is so advanced you have extensive gangrene or unbearable ischemic pain, and either revascularization failed or it's just not technically feasible or safe. We also need to consider acute limb ischemia, ALI, especially if there's been prolonged warm ischemia more than about 6 hours, because that causes irreversible muscle and nerve death. The limb's just not viable at that point.
So ischemia is dominant, but it's often tangled up with infection, right? Especially with diabetic patients. What specific infections are pushing towards amputation?
Infection is the second most common reason, maybe 15% to 31% of cases. The main culprits are those deep diabetic foot infections, necrotizing fasciitis, which is a true surgical emergency, and widespread osteomyelitis that hasn't responded to IV antibiotics and debridements. In these situations, amputation becomes necessary for source control.
Right, you have to remove the source.
Exactly. When medical and surgical cleaning just can't clear it, and the patient's becoming septic or systemically unstable, removing the infected limb is sometimes the most conservative, life-saving thing to do. And, with diabetic foot ulcers, the recurrence rate is so high that sometimes amputation is the only way to stop that cycle.
And we should probably briefly touch on trauma and malignancy too. Less common, but they have their own acute challenges.
Definitely. High energy trauma can cause what we call a mangled extremity. Amputation might be the only choice if there's irreversible tissue death, that critical warm ischemia time we mentioned, or if major nerves are completely cut, meaning the limb would be useless even if blood flow was restored. With a mangled limb, you're weighing potentially dozens of salvage surgeries against ending up with a painful, non-functional limb anyway. For malignancy, like aggressive sarcomas, amputation is needed if limb-sparing surgery can't get clear margins or if there's a recurrence threatening the patient's life. It's about oncologic control.
The thread here seems to be that keeping the limb poses a significant threat, either to life or to future function. The question shifts from can we save it to should we save it?
Precisely.
Given how complex this is, vascular issues, infection, trauma, the patient's overall health, their goals, it's really clear this can't be one person's decision. The sources emphasize that a strong, coordinated, multidisciplinary team, an MDT, is absolutely essential, and good teams actually lower amputation rates and improve outcomes.
A coordinated team approach is crucial. It prevents things from becoming just a series of disconnected consults. And the hospitalist often ends up being the quarterback, coordinating these different inputs. Each specialty brings something unique to the table.
Let's break down those roles. How do the key players influence the decision, starting with the surgeons?
Vascular surgery is obviously central. They assess the blood flow, figure out if revascularization, whether endovascular or open bypass, is even possible and likely to last. And if amputation is needed, they determine the most distal level that has a good chance of actually healing. It's a balance between saving function and ensuring wound closure. Then you need infectious disease involved early. They guide the antibiotic choices, help manage tough problems like osteomyelitis, and confirm we have adequate source control before any big surgery.
And with diabetes being so common in these patients, endocrinology isn't just a consult, they're core team members, right?
Absolutely core. Optimizing glycemic control is vital for healing, but the team needs to be broader. Rehabilitation medicine and physiotherapy need to be involved before surgery. They assess the patient's baseline mobility, their potential to actually use a prosthesis later, and plan the therapy needed. Their input can fundamentally change the surgical plan. For instance, if they determine a patient just doesn't have the reserve to manage walking with even a below-knee prosthesis, that strongly influences the discussion about amputation level or even primary amputation.
Okay, and then we have the really difficult conversations, often involving quality of life, maybe limited prognosis. Who helps navigate those?
That's where palliative care is indispensable, not just for end of life, but for managing chronic pain, addressing quality of life goals, and facilitating those really honest goals of care discussions early on, especially given the high comorbidity burden many of these patients carry. They help ensure the patient's values are guiding the plan. And occasionally, ethics consultation is needed if there's conflict or uncertainty about the best path forward, making sure we respect autonomy and ethical principles.
To try and make this assessment a bit more objective, the sources mention specific tools. Can you tell us about WIfI and GLASS? How do they actually help?
Yeah, these are important tools to standardize assessment. WIfI stands for wound extent, ischemia severity, and foot infection severity. Each gets graded, usually 0 to 3. So a high score across the board, like extensive wound, W3, severe ischemia, I3, and deep infection, F3, points to a very high threat level and a low chance of successful limb salvage. It pushes the needle towards amputation.
And GLS?
GLS, the Global Anatomic Staging System, looks specifically at the limb's vascular anatomy. It grades how complex the arterial disease is, which helps predict how difficult and durable revascularization might be. A high GLASS stage, like stage 3, suggests a very complex diffuse disease that's hard to fix effectively. So if WIfI shows high limb threat and GLASS shows high anatomical complexity, the case for primary amputation gets much stronger. But importantly, these are guides. They quantify risk, but they have to be used within the full MDT discussion, not as absolute cutoffs.
Right. So before any major intervention, whether it's salvage or amputation, the sources really hammer home the need for aggressive medical optimization first. What are the key steps there?
The immediate priority is stabilizing the patient systemically. That means optimizing volume status with fluids, managing blood pressure to ensure good perfusion, not just to vital organs, but to the tissues around the potential surgical site. Poor perfusion is a setup for wound failure.
And if infection is driving things, it's more than just antibiotics.
Oh, absolutely. Immediate broad-spectrum IV antibiotics are crucial, tailored to likely bugs like resistant staph or the polymicrobial flora you see in diabetic feet. But the really critical piece is rapid source control. This might mean smaller initial procedures like an incision and drainage, debridement, maybe even a minor toe or ray amputation just to get the infection under control before the patient is stable enough for the definitive surgery. Sometimes the hospitalist has to really push for that early source control, even if the final plan isn't set.
Another big factor mentioned is glycemic control. What are the targets and how achievable is that in the acute setting?
It's critical for wound healing and infection risk. The general target is a blood glucose below 10 millimole per liter, which is 180 milli-GDL. Achieving that safely often requires an endocrinology consult and usually means moving to basal bolus insulin protocols. The challenge is doing this without causing hypoglycemia, especially if the patient is NPO or having procedures. We know poor control directly leads to worse outcomes, more infections, poor healing, high reamputation rates.
And these patients almost always have significant underlying cardiovascular disease. What needs to be addressed there?
Comprehensive management is key. Strict blood pressure control, usually aiming below 130/80. Aggressive lipid management, typically maximizing statins. Strict smoking cessation, though the immediate benefit might be limited. And ensuring they're on optimal medical therapy, antiplatelets, ACE inhibitors or ARBs, beta blockers if indicated. These steps don't just reduce perioperative cardiac events. They actually improve microvascular flow, which helps with limb outcomes and wound healing. It's about maximizing their physiological reserve.
Okay, this brings us to that central, really difficult decision, weighing limb salvage against amputation. Let's start with when salvage is the clear path forward. Who's the ideal candidate?
You'd favor limb salvage in a patient who is physiologically stable, generally younger, with enough cardiac and pulmonary reserve to handle multiple, potentially complex surgeries and the long rehab afterwards. There needs to be a reasonable expectation that they'll end up with a functional limb, pain-free, useful for walking. This usually means limited tissue loss and infection that's well contained. And crucially, the patient needs strong motivation and good social support. If walking is their absolute priority and their condition allows, you pursue salvage.
But there's a point where trying to save the limb becomes counterproductive, maybe even harmful. When does the evidence suggest amputation becomes the better option?
Amputation is generally favored when there's significant systemic compromise, or if multiple salvage attempts have already failed, that suggests underlying healing issues. It's also favored when tissue loss is just too expensive, like widespread gangrene or massive muscle death, making a functional limb impossible, or if the limb is predicted to end up being a chronic source of pain or infection.
You mentioned functional futility earlier. Can you expand on what that means in practice?
Functional futility is when, even if the surgery is technically successful, say, the bypass graft stays open, the patient doesn't actually gain meaningful function. Think about someone with end-stage renal disease, severe heart failure, maybe they've had several failed procedures already. Even if you achieve another patent bypass, they might spend months in the hospital, face high risks, and still end up unable to walk or burdened by chronic wounds. For that patient, a well-planned below-knee amputation might offer a faster route to being pain-free, mobile in a wheelchair, and having a better quality of remaining life. And remember, for patients who are already nonambulatory, removing a painful, chronically infected limb via amputation can actually be a net positive for their quality of life.
And how do severe comorbidities like advanced kidney disease or poorly controlled diabetes really push the decision towards amputation?
These conditions severely impair wound healing. They cause microvascular disease, suppress the immune system. Patients with ESRD or uncontrolled diabetes have much higher rates of complications after salvage attempts, wound breakdown, infection, graft failure. This leads to longer hospital stays, more procedures, and often ends in amputation anyway, just later and after more suffering. So in these high-risk patients, the team often concludes that a primary amputation offers lower overall surgical risk and a better chance of getting a healed wound quickly, which is the fastest path to rehab. And through all of this, shared decision-making has to be central. It's got to be an ongoing conversation using tools like WII and GLAS to inform the patient about risks and potential outcomes for both salvage and amputation, but ultimately aligning the medical plan with their goals, their values, their definition of an acceptable quality of life. It's about autonomy.
Okay, so once the decision for amputation is made, the next crucial step is choosing the level. The goal is always the most distal level possible that will heal reliably and preserve the most function, right? Because higher amputations mean more functional loss and higher energy cost.
Exactly. The surgeon is thinking about that functional hierarchy. Starting at the bottom, you have toe or partial foot amputations, like a transmetatarsal. These work for localized problems, maybe a single gangrenous toe or a limited diabetic foot infection, provided the back of the foot has good blood flow.
And functionally, what's the outcome there?
Functionally, it's usually very good. Patients keep most of their walking ability with minimal impairment. The downside is there's a higher risk of needing another more proximal amputation later if the underlying vascular disease progresses.
Moving up, the below-knee or transtibial amputation is often preferred if a major amputation is needed. Why is saving the knee joint so important?
Saving the knee is probably the single biggest factor for long-term independence. A transtibial amputation gives much better functional outcomes because the knee provides stability and control. This means patients are far more likely to successfully use a prosthesis and walk independently. The energy cost is higher than normal walking, maybe 40% more, but it's manageable for many people.
Contrast that with the above-knee or transfemoral amputation. When is that necessary, and what's the functional reality?
You typically need a transfemoral amputation if the tissue damage or infection extends up into the thigh, or if a below-knee amputation has failed to heal. Functionally, it's a huge step down. Walking with an above-knee prosthesis takes 60% to maybe even 100% more energy than normal walking.
Wow, double the effort.
Yeah. That high energy demand means many patients, especially older ones with comorbidities, can only manage limited walking inside the house, if at all. Rates of independent ambulation and prosthesis use are much lower. Losing the knee really impacts balance and requires complex, energy-hungry prosthetic components. It's often the difference between walking independently and primarily using a wheelchair.
And thinking about improving those outcomes, especially regarding chronic pain, what about newer surgical techniques like targeted muscle reinnervation, TMR?
That's a really important development. Traditionally, when nerves are cut during amputation, they can form painful neuromas, leading to residual limb pain or phantom limb pain. TMR is a technique where the surgeon meticulously attaches those cut nerve endings to small nearby motor nerves, supplying muscles that aren't critical for function.
So the nerve has somewhere to go.
Exactly. It gives the nerve signals a target, which seems to reduce neuroma formation and potentially the severity of chronic pain. For patients getting a transtibial or transfemoral amputation, considering TMR as a proactive way to potentially improve long-term comfort and maybe even enhance control of advanced prosthetics later on. It's shifting the focus from just removing the limb to optimizing the remaining interface.
So the surgery's done, the acute issue is addressed, but then the real recovery journey begins. And we can't ignore the psychological impact. Losing a limb is massive. The stats suggest depression and anxiety are really common, to be 20–30% prevalence.
It's incredibly common and, frankly, something we often don't manage well in the busy acute setting. Things like low self-esteem, poor coping strategies, lack of social support, these are known to worsen functional outcomes. And the whole hospital experience itself can be overwhelming and anxiety-provoking. I think we have a real responsibility to screen for psychological distress, maybe using simple tools like the HADS score, and get behavioral health, social work, even peer support involved early. Helping patients adjust psychologically is just as vital as healing the wound.
Okay, let's talk about immediate post-op care. Pain is always a huge issue.
It has to be managed aggressively, multimodally, right from the start. That means using regional nerve blocks, maybe epidurals, plus systemic meds. And you're dealing with two kinds of pain. The residual limb pain, which is surgical pain, and then phantom limb pain, that neuropathic pain felt in the missing limb. Phantom pain is incredibly common, maybe up to 80% of patients experience it. If you don't treat it early, often with drugs like gabapentin or pregabalin, it can completely derail physical therapy and recovery.
And managing the stump itself, the residual limb, is key for fitting a prosthesis later.
Absolutely. You need meticulous wound care. The goal is to get a well-shaped, non-swollen, durable stump. Using rigid or semi-rigid dressings, especially after a transtibial amputation, can really help control edema, protect the wound, and potentially shorten the time until they can start prosthetic fitting. At the same time, you have to prevent contractures, especially knee flexion contractures after a BKA. That means starting physical therapy right away with positioning and range of motion exercises. A contracture can make wearing a prosthesis impossible.
And getting patients moving early is crucial.
Early mobilization and getting them to a specialized rehab facility promptly are strong predictors of success. It leads to shorter hospital stays, faster return to walking, but the management doesn't stop at discharge. You need long-term follow-up, constantly monitoring the other leg because the risk of disease there is high, and making sure they stay in that optimal medical therapy, the statins, the BP meds, tight glucose control. It's all about secondary prevention to keep them functional.
We have to confront the prognosis here, which can be quite stark. Major amputation signals severe underlying disease, and the mortality rates are high, aren't they?
They are sobering. 30-day mortality can range from 5% up to maybe 17%. One-year mortality is consistently grim, often 35% to 40%. And the really shocking figure, especially for PI patients, is that 3-year mortality can approach 71% in some studies.
71% within 3 years. That's incredibly high. Doesn't that argue for integrating palliative care much, much earlier, maybe even from the initial diagnosis of limb threat, rather than waiting until things look bad?
I think that's exactly the conclusion we should draw from those numbers. Many of these patients die from their underlying heart disease or kidney disease, not necessarily a problem with the amputation site itself. These rates absolutely mandate a shift towards having palliative care involved early for comprehensive symptom assessment and crucial goals of care discussions. We need to recognize we're often treating a manifestation of a systemic, life-limiting illness. And we know the predictors of poor outcome: advanced age, diabetes, kidney disease, frailty, and especially being non-ambulatory before the amputation. Those factors predict higher mortality and lower chances of successful prosthetic use.
So given that prognosis, success really isn't just about survival. It's about maximizing function and quality for the time they have left.
Exactly. Functional recovery, their quality of life, it really hinges on whether they can walk and use a prosthesis. And as we said, that's much more likely with a transtibial than a transfemoral amputation because of the energy cost. But even with the best outcome, getting back to work, back to their previous social life, is really tough for most, which just highlights why comprehensive post-discharge rehab, ongoing medical care, and dedicated psychosocial support are absolutely essential, not optional extras. It's about maximizing meaningful life, maintaining dignity.
So we've covered a lot today in this deep dive, from those absolute life-over-limb indications and the vital multidisciplinary team, through choosing the right amputation level for function and addressing the significant long-term outcomes, including mortality and psychosocial needs.
And I think from a quality perspective, we have to look beyond just whether the stump healed. We need to track our outcomes, ensure that optimal medical therapy continues long-term, focus on preventing disease in the other limb, and really understand the long-term functional status and prosthesis use of our patients.
Which leaves us with a really challenging question for clinical practice. Considering those incredibly high 3-year mortality rates, potentially near 71% for complex patients after major amputation, how do we ethically balance aggressive, resource-intensive attempts at limb salvage against ensuring that patient achieves the best possible quality of life in the remaining years? Does this mean prioritizing comprehensive palliative and psychosocial support right from the very beginning, the moment amputation first enters the conversation? That potential shift in focus from purely technical salvage towards optimizing quality of life within a limited prognosis might be one of the most critical challenges we face.